What's up, guys? Energy Physio back for another Mythbuster, talking about low back pain. Low back pain is super prevalent, and not to say that low back pain itself is a myth, but I think the way we think about it in general, even as clinicians sometimes, clinicians and the general public, the way we think about low back pain is somewhat of a myth. And I think a lot of that is driven by our poor education in the past. I think that's also driven by this high output of imaging done way too early in the diagnostic process is really pushing a lot of this. Your low back pain is this, or your low back pain is that. But the truth is, if you treat an image, it might not get better. We always need to treat dysfunction. We always need to treat deficit. We should never treat an image. An image, like an MRI or an X-ray, should only be an adjunct to what we can already pretty confidently know by a detailed history, movement dysfunction that we see in our athletes and our patients, whatever that might be. So we're going to talk about a couple of key things when we're talking about low back pain and kind of dive into this idea that low back pain isn't always low back pain. And when you get an image early that may show some structural changes, how that can perpetuate this idea that my image says this and therefore my low back pain is that. So I'll just get a couple things out of the way. First and foremost, when we talk about low back pain, the two most common diagnoses people are getting are either disc herniation or nerve root impingement. And here's what we need to know about those two things specifically. When we talk about disc or nerve root impingement, those things are always going to be associated with a preferential movement or a direction of movement that is good and a direction of movement that is bad. Particularly with the disc, typically flexion is going to be bad. Flexion is going to feel worse. It's going to cause more pain, may cause pain to travel down the legs if it is a true disc herniation creating the pain. On the opposite, nerve root impingement is typically going to be worse with extending backwards. And the reasons for those are when you flex forward, it puts more pressure on the disc backwards. It'll make more disc material extrude out the back and potentially press on nerve structures. Whereas nerve root impingement is typically worse with bending backwards because as the nerve roots exit through the spine, those holes are called foramina. And when you extend, the foramina close down. So if there's already a narrowing of that space, closing it down is going to cause to pinch the nerve root earlier than a normal healthy spine. And so when we talk about diagnosing disc problems or nerve root problems, we can always find that preferential movement. And that allows us to jump into a treatment very quickly and very easily and very specifically based on what movement feels good and what movement feels bad. More often than not, when I see athletes or patients in the clinic, they come in and they don't have a preferential movement. Their pain is very vague, it's not very specific, it doesn't respond to any one thing better than another. It may fit into some of this a little bit, but it's not necessarily following a true pattern of disc herniation or a true pattern of nerve root impingement. These people are also coming in with an MRI already that may show you have a disc herniation or a disc bulge is pretty common. They say you have a disc bulge at L2, 3, and 4, but their pain presentation is not a disc bulge at 2, 3, and 4, but it's really hard to work that out of the patient's mind when they've seen a doctor who prescribed getting an image. They got an image that said they have a disc bulge at L2, 3, and 4, and therefore they're already in this mindset that I have bulging discs and that's why I have pain. But when we do differential diagnosis in the clinic based on movement patterns and movement dysfunction, they don't fit that. And so there are a lot of good studies out now that show, especially for low back pain, an MRI too early actually makes low back pain worse because it feeds into this idea that your image is what your pain is, and it's just not true. A lot of good research showing that hundreds of Americans had an MRI study done. All of them had some structural deficit in the spine, a disc bulge or something like that, or most of them, but they were all asymptomatic. And that's just makes the point that you can have structural dysfunction in the spine that does not necessarily correlate with your pain. And so MRI is too early. We got to start moving away from that. You can respectfully ask your doctor or tell your doctor if they supply an image, hey, can we try something else first? I don't want to jump into this too quick. It's your money. You have every right to do that. A good PT can diagnose what your low back pain is completely. And then if there's something that's left undone, then it's a great time to refer back to the doc and maybe then get an MRI if you can't quite figure this thing out. And so moving forwards, we're going to take note that a disc probably is going to feel bad flexing forwards. A nerve root is probably going to feel bad extending backwards. There are some nuances in there that can be a little different, but classically, those really kind of fit just like they are. So we're going to take a look at some of the other things that I see a lot of that cause low back pain. The first being the pelvis. The pelvis should sit completely level and the spine should sit totally perpendicular right on top of it. I see a lot of people whose pelvis has shifted out of position, and what that does is a couple of things. One, it makes the pelvis sit like this at rest, which means the spine sits like this at rest to compensate for that. And so we get some weird pinching down on this side, we get some weird lengthening on this side, and this just in itself is enough to create ligament tension, muscle spasming over here, and that can present a lot like low back pain. The other thing that can happen, particularly with the pelvic obliquity, is that when the pelvis changes position, then you're going to get a leg length discrepancy where one leg appears longer than the other based on the way the pelvis is shifted. What happens in that case is the nerves that exit the low back and travel down the leg, your leg is a fixed length and it's a fixed distance from your low back. And so when you add length to that, it adds tension throughout the entire neural system. And so the pelvis can sometimes present just like a disc herniation or a nerve root impingement because it's tractioning the nerves and creating this radiating and referred pain down the leg. The next most common thing I see outside the pelvis, and this can also be generated by a pelvic dysfunction, is what are called trigger points. So keep your eyes out on Facebook over the next couple of weeks and on Instagram. I'm going to start posting some really specific trigger point referred pain patterns so you can start to see that and correlate types of pain you have with something that may be different than a disc or a nerve root. What happens is, in a trigger point, let's say here's the pelvis, here's your legs, here's low back. There are muscles all through the spine here that run long ways, cross ways. We got big muscles that attach to the hip from the spine. We've got the muscles of the hip themselves, and then the muscles of the glutes, and all these smaller muscles inside the glutes. Any muscle has the capacity to form a trigger point if introduced to too much load or too much stress. When the pelvis changes position, it automatically introduces more load and trigger points develop. Or we could be dealing with things like, hey, I did heavy squats 3 days this week, and now I've developed some trigger points. Well, what a trigger point does is it puts a kink in a muscle fiber that disallows normal blood flow and oxygen through the muscle fiber. The body has a pH of right about 7. It's very neutral, which means it's not very acidic, it's not overly basic, just neutral. When you get a trigger point that disrupts the flow of oxygen and blood flow, you get a blood pooling on this side and you get no blood flow and oxygen on this side. That causes the pH to go down. So this area of the muscle gets very acidic and in turn gets very tender. So when we see these tender spots or knots in the muscle, those are trigger points. Now, a trigger point, we'll just take this one example because it's the most like a low back referred pain pattern that we can get. A trigger point in the glute medius or glute minimus can refer pain all the way to the foot. It presents a lot like a nerve referred pain pattern. It's very sharp. You move a certain way and it sends you a zinger right down the leg. But in reality, it's just this trigger point in this muscle. The pain referral mechanism is pretty complex. We're not going to get into that. But I see this more times than not. Somebody has pain all the way down their leg and it's coming from a trigger point in a hip muscle, not the back at all. A way that you can start to diagnose is your referred pain more disc or nerve root versus trigger point is a disc herniation that's pressing on a nerve, or a nerve impingement from the spine has a pain referral pattern that spirals down the leg. So we've got kind of L1, right up here high in the hip, L2, L3 gets down by the knee, L4 gets down into the lower leg, L5 hits the, kind of spirals down and hits the big toe. And then when we start getting into S1 and S2, that's kind of straight down the back of the leg. And so if your pain pattern isn't spiraling, or you don't have numbness and tingling in a spiraling pattern down the leg, good chance it might not be nerve root or disc, it might be a trigger point. This trigger point pain pattern is almost just dead down the side of the leg into the foot. And so those are just some ways that you can start to think about your own low back pain. Does it respond to a certain movement and get worse with another, or vice versa? Does the referred pain travel in a spiraling pattern versus straight down the leg? And those are some ways you can start to kind of self-diagnose and start to understand what is your low back pain coming from. And we can even start to look at trigger points in the glute max, refer pain into the low back. So nothing going on in the low back, but a trigger point here is referred low back pain. And so it's not always is the low back pain coming out of the back and going somewhere else, but is the low back pain starting somewhere else and coming to the low back. So think about that in your own life. What does your pain respond to? What does it not? Let's not jump the gun on our MRIs and diagnostic imaging. Let's do a little more differential diagnose through movement and palpation and some of these things that are a lot more cost effective and effective for truly diagnosing what's going on. Let me know what you think. See you later.